Internal and external root resorption. Root resorption is characterized by the loss of dentin, cementum, and/or bone that occurs as the result of either a physiologic or pathologic process. Physiologic root resorption occurs in the deciduous dentition, resulting in exfoliation and subsequent eruption of the succedaneous dentition. Pathologic root resorption may occur after injury, such as mechanical, chemical, or thermal insult. Root resorption is typically classified as either internal or external, as seen in Figure 1. Internal root resorption occurs within the pulp chamber or canal and involves resorption of the surrounding dentin via odontoclasts. This results in enlargement of the size of the pulp or canal space at the expense of the tooth structure. This condition may be transient and self-limiting or progressive. When internal root resorption occurs, it is most likely a reactive response to something abnormal happening in the jaws. Most of the time, the activation of odontoclasts that facilitate the resorption is unknown, but may be related to inflammation of the pulpal tissues caused by acute trauma to the tooth, direct and indirect pulp capping, pulpotomy, and enamel invagination. From a differential diagnosis perspective, the use of a cone beam computed tomography has considerably improved our ability to diagnose the internal root resorption. However, despite the technological advances to visualize this pathology, root canal therapy remains the treatment of choice for this condition. In Figure 2, a radiolucency is observed in the canal space of the premolar, which indicates the presence of internal root resorption. External root resorption occurs as odontoclasts resorb the outer surface of the tooth. This most commonly involves the root surface, but may also involve the crown of an unerupted tooth. The resorption may involve cementum and dentin, and in some cases can gradually extend to the pulp. Because the recruitment of odontoclasts requires an intact blood supply, only portions of the tooth with soft tissue coverage are susceptible to this type of resorption. This resorption may occur to a single tooth, multiple teeth, or, in rare cases, all of the dentition. The process of primary tooth exfoliation is associated with external resorption. As secondary teeth begin to develop and erupt, the primary teeth roots resorb. Over time, the crowns become loose and fall out with only a fraction of the root structures they once had. It is unclear whether the odontoclasts in this natural external root resorption are the same as the osteoclasts in other forms of bone remodeling, but it has been shown to progress in a similar way to bone remodeling using the RANK-RANK-L receptor ligand system. Abnormal external root resorption could be due to many etiologies consisting of inflammation, aggressive orthodontics, re-implemented teeth, tumors, cysts, excessive force in mastication, or impacted teeth. Resorption has also been found to be correlated with the amount of tooth movement in orthodontic patients and the location of the teeth. More commonly, though, the etiology is unknown. In Figure 3, the root apices of the teeth appear shortened and blunted rather than their normal tapered shape, indicating external root resorption. Internal root resorption is more common in permanent teeth than primary teeth and is most often seen in central incisors, first molars, and second molars, with the prevalence being greater in males than females. When the lesion is in the pulp chamber, a pink spot can appear through the enamel when the dentin is perforated, as seen in Figure 4. You can see the pink lesion through the enamel on the lingual of tooth number 9. Once the enamel is perforated, infectious pulpitis can result because bacteria now has an easy access to the pulp chamber. When the lesion is isolated to the root, the tooth is usually asymptomatic. If the resorption is significant, the tooth becomes very weak and can fracture. The pulp can also expand into the supporting structures such as the PDL, gingival sulcus, or periodontal pocket, which will often result in pulpal infection. External root resorption is seen more commonly in the mandible than the maxilla and is seen most often in central incisors, canines, and premolars. It is also commonly seen in the apical or cervical regions of the teeth, often due to orthodontic forces. Many patients are unaware that they have external root resorption because there are often no signs or symptoms. The tooth involved is also infrequently mobile, even with considerable loss of tooth structure. Once the resorption becomes severe, pain or root fracture could result. Internal root resorption occurs within the pulp chamber and/or the root canal. Figure 5 demonstrates this occurring in the pulp chamber, while figures 6 and 7 demonstrate it occurring in the root canal. A well-defined radiolucency will appear smooth and continuous with the pulp chamber and/or the root canal. External root resorption is most commonly observed at the root apex. However, it can occur along any portion of the tooth located within the bone. A loss of lamina dura around the root apices occurs, which is demonstrated in Figure 8. Blunted rather than tapered root apices, as well as an altered shape of the tooth, are other characteristics of external root resorption and are visible on the radiographs in Figures 8 and 9. Internal resorption can be difficult to determine from external resorption when it occurs over the facial or lingual surface of the root. A radiograph of the tooth can be examined to determine if the outline of the pulp chamber and/or root canal is visible. Different angulations of radiographs can be utilized to determine whether the chamber and/or canal outline is continuous and encompassing the radiolucency. If it is continuous, this indicates the radiolucency is more likely to be internal root resorption. Dental caries on the buccal and lingual surface of roots can commonly be confused with both internal and external root resorption. The main difference between root caries and root resorption is that the caries are typically located near the crown on an exposed root surface, while root resorption is more commonly seen apically. Carious lesions appear radiolucent with poorly defined margins, and the process occurs from the cementum towards the pulp. If the diagnosis is questionable, a clinical exam may help differentiate between the two because buccal and lingual root caries should be clinically observable. Another process that can be confused with root resorption, especially external root resorption, is early pulpal death. In early pulpal death, there is an incomplete formation of the apex of the root, and the foramen is visibly open. The walls of the canal diverge or have a blunderbuss appearance. While short, blunted root apices are observed in both, external root resorption typically appears with complete apex formation. A common treatment for internal root resorption is non-surgical root canal therapy using gutta-percha and MTA in regions of perforation. Figure 13 shows a periapical radiograph of the first molar exhibiting internal root resorption. It was then verified by CBCT imaging as shown in Figure 14. This resorption showed a perforation of the distal root. A root canal was performed, and Figure 15 shows the 18-month post-op radiograph with no signs of continued root resorption. Other treatments include retrograde apical treatment or extraction if resorption has progressed to the point where the tooth is too structurally weak to be treated. In external root resorption cases where the cause is known, the treatment consists of removal of the etiologic agent. If the resorption is on an accessible surface of the root, curettage of the defect and placement of a restoration usually stops the resorption process. Glass ionomer is often used as a restorative material due to fluoride release and biocompatibility. Figure 16 demonstrates pre- and post-op treatment radiographs of external root resorption restored with glass ionomer.